Hi, everybody. My name is Afaf Osman. I'm a physician and a board member of the Sudanese American Medical Association, also known as SAMA. First of all, I want to say that one of the main reasons I joined SAMA is because of SAMA's investment in women's health programs and because of SAMA's commitment to advancing women's and children's health in Sudan. Women in Sudan are especially vulnerable, and gender inequality leads to healthcare inequality and leads to death and suffering. So SAMA believes in um, advancing women's health and women's rights in Sudan. Today, our topic is female genital mutilation, which is a very important healthcare crisis and a social crisis, a human rights crisis in Sudan and in the neighboring countries, and unfortunately continues to be practiced against young women in Sudan. Um, Before we delve into female genital mutilation, I wanted to highlight one of SAM's efforts in advancing the health and well-being of Sudanese women. This is a program that I personally feel very invested in and very proud of. This program is activism against gender-based violence in Sudan. Gender-based violence continues to be a huge issue in Sudan, unfortunately, due to all the conflicts that the country has gone through, and also due to specific challenges, social and economic challenges. So in 2019, SAMA organized an awareness session at two high schools in Sudan, in Khartoum. These are all girls high schools. And we did this in collaboration with Ahfad University. Ahfad University has a gender-based violence training center through the Ahfad Trauma Center. And this trauma center has been there since 2012 and has trained in multiple states in Sudan, including Darfur, Gadaref, White Nile, in multiple areas. In collaboration with the Ahfad Center, a trauma center, we organized two sessions at girls' high schools in Khartoum with the idea of reaching out to these girls in their schools. We focused the training on girls' rights to education, and as we know, access to education it raises awareness among girls to their rights and improves their health and improves all of their lives, essentially. We also focused on the harmful effects of early marriage and early childbirth, which unfortunately is an issue that continues to happen in Sudan. We've done some training on hygiene practices and, of course, female genital mutilation, with the hope that going to these girls in their high schools will give them the power of knowledge and will raise awareness so that they can, spread this knowledge among their colleagues and their peers and say no to these practices. So we hope to continue this collaboration with the Ahfad Trauma Center and to expand these training sessions to include other areas outside Khartoum. And this is only possible through your donations to our organization. We are a donation-based organization. I encourage you to donate so that we can continue these efforts in Sudan. Appended some of these programs. With that in mind, I will introduce our panel. First of all, thank you to our panelists for joining us today. I think our first panelist speaking today is Dr. Bedri, Nafisa Bedri. So I'll introduce her bio. Dr. Nafisa Bedri is an experienced professor, researcher, and regional trainer in the field of gender, reproductive health, management, and policy analysis skills. She has written and developed several publications and training materials in these fields. Dr. Bedri carried out several researchers at national and regional levels in the area of gender and women reproductive and child's health for different bodies and collaborated with different institutions at regional and international levels. She's an activist and regional consultant in the area of women's reproductive and sexual rights, maternal and child health, violence against women, girl-child marriage, female genital mutilation, and HIV/AIDS, and also integration of gender and rights in reproductive health systems and in gender analysis of health services and training. So thank you, Dr. Bedri, for joining us. We also have Saria and Nageeb from the Youth for Change, which is a youth-led initiative in response to FGM campaign in the UK. We also have Dr. Ellen Greunbaum, who is a cultural anthropologist specializing in women's health. And I will introduce the bios of two other speakers right before their presentation so that it's fresh, if that makes sense. So with that, we can start with our first presentation from Dr. Nafisa Bedri, titled Overview of Female Genital Mutilation in Sudan.
Good evening, everybody, and good afternoon for those of you in the US. And thank you very much for this invitation. I'm really happy that we're doing more and more collaborations with Sama on these very important issues. My presentation today, or my talk, is going to be about the overview of what's happening on FGM in Sudan. Of course, there is a lot that's happening. I'll try to capture some of it, at least just to give you an idea about what's happening right now.
Prof. Nafisa, you are on mute.
Yeah, I don't know why I was on mute. So to give you a rough idea about what's happening around the world, and we've heard some of it already in the video that was just played shortly. Currently, there are 3 million girls around the world at risk of undergoing FGM, including in Sudan, in the UK, in the US, and many other countries. 200 million girls are currently living with, and women living with the consequences, which is something that still many of the services are not yet dealing with. I lost my screen, I'm sorry. So we know that FGM is practiced in many countries around the globe. It's practiced in 28 African countries, but it's also found in other countries around the world, like in Europe and in Asia and in the Middle East, and of course, especially among migrants from countries with very high prevalence, who continue to practice FGM as they move on. Next slide. I'm not sure if I can move it from here. Okay, this is just a summary. You can move to the slide after it. I just want to go to the. So what I'm going to talk about today is as I said, the current situation in Sudan. I will also give some ideas about the challenges of implementing the campaign, particularly with COVID-19, and I will touch upon the issue of the law and how it can be integrated within the campaign. So you all know that FGM is, as defined by the WHO, it involves any procedure that involves partial or total removal of any of the external female genitalia or other injury to the female genital organs, whether for cultural, religious, or any other non-therapeutic reasons. And it's divided into 4 types. And in Sudan, of course, everybody knows that we have type 3, which is the infibulation, which is one of the worst types of FGM. Of course, all of them are bad, but infibulation is one of the worst ones. And in Sudan, people actually call the infibulation pharaonic circumcision because they tend to think that it came from the pharaohs, and they tend to give the name Sunnah by wrongly believing that it was advocated for by Prophet Muhammad, peace be upon him, for type 1, which is the clitoridectomy. And of course, both of these things are very wrong. Everybody knows that. So next slide, please. I wanted to establish from the start that FGM has no clinical or psychological or moral benefits at all. And on the contrary, it has a lot of immediate and long-term health problems. Some of them, they happen immediately at the moment when the girl is being cut, and some of them take place or appear in the as the girl grows up. So the consequences, the health consequences of FGM, they continue to be there with the woman as she grows older. And as I said, some of them are long-term ones, some of them are injuries, some of them, they influence her fertility. And so, and it costs a lot of money to treat actually the health complications of FGM in high prevalence countries. It costs up to 1.4 billion US dollars per year just to treat these complications. So it is not something that people should take very lightly. Okay, so if we move on to the next slide. Um, so what's happening in Sudan? What's happening in Sudan is that unfortunately, we don't have a lot of recent national data because the last data we have was from the multiple indicators cluster survey of 2014. Hopefully this year there will be the third one. But what we have so far and what we know from the studies and from these existing surveys is that there is a very high knowledge about FGM among women and among the community. Although there is some kind of state variation. In some states, the knowledge is still very low. In some states, the knowledge is very high. Particularly, these are the states that receive most of the campaign. The data shows that 7 out of 10 girls aged 0 to 14 will be cut before the age of 15. And only 4% of daughters. There is variation in relation to the state of cutting of the mothers. So mothers who are uncut, only 4% of their daughters will be cut versus 74% of women who have mothers who have been cut. So the state of circumcision of the mother was one of the most important elements that were found when people did a trend analysis for the mix survey. And it was even stronger than all other characteristics of the mothers. And that's why that made us believe that unless we invest in younger generations and making sure that these younger generations grow to become uncut mothers, we are not going to stop this chain of the practice. Also, we found that the survey found that mothers who support FGM abandonment and use the term Salima are less likely to circumcise their daughters. They had more, I would say they had more support for the abandonment of the practice. And the word Salim, of course, as you may know, comes from the campaign, the national campaign that's been launched in 2008 in Sudan. And the idea behind it is to use social marketing techniques to help the community to change the way it looks at the uncut girl. So instead of naming the uncut girl the nasty word that people use in Sudan, is to replace that with the word Salima, donating that there is a positive element in the fact that you are leaving your daughter without cutting her, and that means you are leaving her Salima. And of course, there are the colors of the Salima. You see them on the side of my slides here, the orange and the green. So the idea behind Salima is to make the families less feeling guilty in terms and become more attracted to the fact to leave their girls uncut. So when we go to you can go to the other slide. So the other thing is that we found there was a huge variation in rural urban. setting. In rural areas, more girls are at risk of being cut. We found that women, mothers who were cut at an early age, they tend to cut their uh, their uh, their daughters more, so they have more support for the continuation of the practice, and they have more percentage of cut girls. And we believe this is where the link between child marriage and FGM occurs, and they are all, as we heard shortly, they are all related to issues of gender inequality and women, lack of women empowerment, and the issue of having uh, reducing the right of the woman herself to control her body, or to have the right to choose when to marry, and her access to education, as Afaf just talked about before. Can you go to the? I'm sorry, some of the slides are repeated. I will explain why after I finish. Um, so, despite all this, we have seen decline across the generations. So, if you compare women who are 15 to 49, you will see that when you look at the younger generation, 0 to 14, the level of cutting is getting less. So the statistics now are showing that among women 15 to 49, the prevalence is 89%. So it's almost 9 out of 10 women. But if you look at those who are 0 to 14, the prevalence is 37%. Some people may say, but these are still within the age of cutting, so they may still be cut. But at the end, it's still there is a fewer number of, and the trend is showing the decrease that's taking place among the different generations, which is a good sign, which means that there is some kind of move towards abandonment of FGM. But having said that, we have to be very careful in this, because from our own studies that we have conducted at Ahfad University for Women across different states, we found that people, even when we were doing the assessment for Salima MNE in the 18 states of Sudan, we discovered that people, when they tell you that we don't cut our daughters, they actually sometimes mean that they cut their daughters type 1 only. So many communities, they don't think of type 1 as a type of cutting. And that makes it sometimes very difficult. So that's why in the mix and in all the recent surveys, people have been asking questions to explain. Like, the question will not be whether you have cut your daughter or not, but the question will be whether you have attempted to remove any flesh from her external genital organs, or to do any kind of operation. Was there any sewing taking place or not? So that they will make sure that people understand what we are talking about, and not we are not just saying that because in type 1, presumably there shouldn't be any stitching. But if there is any stitching, then of course this is not type 1. So I'm not sure if people understand my point here. So we tend to look at these percentages with very great. Uh, it's happy. I mean, it's good that there is a decrease. At least it shows a positive attitude. But in some places, people may still be doing type 1.
Yeah,
Okay,
I
next slide.
understand your point. I just wanted to say that.
Yeah,
Mhm.
yeah. Okay. Uh, Next slide. Uh, so the attitudes of women, again, which is very good, because now we have seen more women who are actually pro, at least more than half, or we can say 1 in 2 women in Sudan, they are pro abandonment of FGM. And of course, urban dwellers, people who live in urban areas, they have more support for discontinuation than women who are in rural areas. And if you look at the graph, you can see a huge difference where women, only 28% in urban areas, they actually support the continuation of the practice, in comparison to 47% in rural areas. So that shows there is still more need to do more work among rural women. This is a challenge because there is still in Sudan, there is still this dynamic movement between urban and rural areas. And so uh, the whole thing is still very dynamic. So whenever you say I have achieved almost total abandonment in one area, it takes only one or two families to come to this area to bring people back to practicing. And and there is also some state variations. So some states are well advanced in their abandonment efforts and in bringing change than other states. And again, this depends on the start of the campaign, the existing of laws in these states, the number of people working there, and the leadership of the state itself. Okay, can we go to the other one? So what makes people want to do FGM? Of course, we came to know that it is about social norms. People, they want to feel accepted. People, they want to feel they conform to what the society says. The society says we have to cut our daughters. So, and the society builds a lot of stories and they build a lot of excuses for this so that they can continue. Uh, when we come to the health effect, I believe that the health effect was brought mostly not by the society, but by the way we have addressed the earlier campaigns when people were just focusing mostly on the health complications. So that gave people the idea to start thinking about how healthy it is to do FGM. But then there are issues related to religious requirement, and we all know that people still believe that at least type 1 was required by religion, although it is not. And people showed that that saying was hadith was not a strong one. Then there is the issue of identity. Some people believe, especially people who move outside the country or outside their own regions, that in order for them to maintain their identity, part of it is to cut their daughters. And that's why we don't see a lot of change happening among people who migrate from countries of high prevalence to countries where there are strict laws against the practice, like in the UK and the US. They still do not change the practice easily because it's an issue of identity. Then there is the issue of the reference group, and that applies to everybody in the household, not only the head of the families. Even for young girls, if the young girl is not very well aware about why she has not been cut or why her family is taking this stand, she may be forced by her reference group, which is her peers in the school, and bullied and so forth, that to come back and ask to be cut. The income is mainly for performers of the practice, which, as you will see shortly, it's mostly midwives and traditional birth attendants. So it has become an issue for them, especially that many of the midwives in Sudan are still not part of the health system, so they are not paid regular salaries. So they used to depend on the money they get from delivering babies and providing services. But FGM it pays more money, and the more the campaign is stronger, the more money they are paid, because especially after the midwifery oath, it became even more expensive. Because if the one is get caught, she will lose her license as a midwife because of the medical council statement and the oath that the midwives are required to take. And now with the law, I believe it's even going to be more expensive. I left marriageability at the end because marriageability is a very interesting element. Every time we do an in-depth research, it comes out as a reason, but sometimes as a reason for doing the practice, and sometimes as a reason for leaving the practice. When we did our study last year in Kassala and Khartoum state on abandoning families that have abandoned the practice, marriageability came as a very important factor because people starting to realize that young men they will not, people were saying young men will not marry my daughter unless I cut her. So if she is not circumcised, she will not find a decent husband. Even some of them, they leave the girl uncut until she gets, somebody asked for her hand. And as one woman told us, when he asks for her hand and he brings all the gold and all the things, then we take her to be cut. Now, in a very recent study that we are doing with Plan Sudan, in 3 states also, we found in one of the states that marriageability has changed in the sense that people are stopping doing the practice because they were told by many young men that they will not marry a cut girl. So they want to keep their daughters intact and salimas so that they can find a decent husband. And so marriageability is still a very huge issue. And we tend, from our own studies, believe that this is like at the heart of this issue, as Jerry McKee said before in one of his writings. So it's still an issue that requires more and more uh, exploration. Can we go to the other one? And again, these are just the reasons people give us. They say that it cleans the girl for marriage, it ensures social acceptability, it makes her more conforming to religious and traditional debates, so nobody's going to say our daughter is not a good girl. People believe that she will be less, she will have less discharges, she will be more clean, she will preserve her virginity, and she will please her husband better. These are the reasons actually people give in every survey. But of course, after probing, people come up with issues related to marriageability or related to this is our identity, this is how we know things happening in our community for a very long time. Next one. So the age of practice, of course, Sudan is not like other African countries. Usually it's practiced between the age of 5 and 9. So it's way younger than other countries like Kenya and Ethiopia. And it's rarely practiced after the age of 14. But now, worldwide, of course, it ranges between infancy and 15 years. Now it is done at a younger even age. And we have seen parts in country where 10% were cut actually between the age of 0 to 4. And we believe that this is done at a young age. Again, from one of our studies on medicalization, people were saying we prefer to cut our daughters at a younger age so that they don't remember the trauma of the operation itself. It also makes her more quieter, so she doesn't know anybody to go and report, because many of the campaigns are involving kindergarten and school kids, and they are becoming more aware of the practice, so they can speak actually and say, I have been subjected to this, or even if they don't understand, they will use descriptions like I had henna on, or I was taken to this woman and she did that thing to me. And so in a way or another, if she is in a very aware age, she may be able to report. And that actually, and we expect that maybe with the law, they may even go at a younger age. In some parts of Sudan, they do it as early as 7 days. They do it with when they do the naming ceremony, they do the FGM with it immediately, which is very difficult. And they say because it heals quicker and it doesn't have any complications. So they tend to apply the same rule as the male circumcision here. Next slide. So who does it? It's mostly, as I said, it's 63% by trained midwives. So in Sudan is considered one of the countries that have high medicalization. Medicalization is defined by when the practice is actually done by a medical or health provider in any setting, at home, in a hospital, in a health center, in the car, whatever it is. If it's done by a health provider, then this is considered medicalization. And medicalization is wrong because not only it makes the practice continue further, it gives it legitimacy. It makes it more appealing for the people, because we know that in our communities people still believe in health providers. So they would say, it was done by the midwife. She knows how to do it very well. I remember in one of the interviews, one woman told me, if you just train these female doctors for us how to do good circumcision, you will help us a lot, because then they will know how to do it perfectly. So it's not just, the community doesn't want only to end up with a trained midwife. They would love to have doctors practice it as well. And we do not want to end up like neighboring countries where 75% is done by doctors. Still, our rate by the doctors is very low. It's below 1%. I think it's 2%, but it's still, the idea that it's performed by trained midwives is very difficult. And it has increased over time from 50 something to 63% or to 70%, even in some states, like in Khartoum state. Next slide. So I come to the campaign in Sudan. Of course, everybody knows Sudan was the first country to do legislations against the practice in 1940s. And then these legislations were dropped and brought back and dropped. And then at the end, when we reached 2013, and we had this Article 10, Article 13 in 2000, Article 10 years in 2013, the idea was to drop, to make all forms of FGM illegal, and not only type 3. And this was dropped by the president at that time from the old regime. And then we ended up with nothing. We just ended up with words talking about, they were only referring to type 3, allowing people to feel that type 1 and any other type are actually, including recircumcision, are legal. And so the efforts and the advocacy efforts by the National Council for Child Welfare and all its partners, governmental, non-governmental partners, and the campaign that's been going on, they managed to draft. They started in 2016 to draft the law that was recently approved. That's the change in the Article 141, which actually criminalizes all forms of FGM. There are certain states in Sudan that have laws. There are 6 states. 4 of them, they have laws that criminalize also FGM. But it's only recently that we had a case that was taken to court. I mean, the first state started was South Kordofan in 2007. So until we had the national law last year, there was no single case that was brought to court. There were some attempts to bring some cases, but they were always at one point, with interference of people, dropped down. Next, I think I'm coming to the end of my, okay. I just wanted to show that the campaign in Sudan includes all partners, and it includes different kinds of activities. The idea behind it is to build social movements and to make the community leading the campaigns. And it works with different groups, men, women, religious leaders. I think if you go to the next slide, so it includes everybody, men, women, religious leaders, university students, young men. Go to the next one. Health workers, school teachers, media people, community-based organization, protection groups, youth groups, lawyers, even people from different other ministries, like the Ministry of Guidance and Endowment, الشؤون الدينية والأوقاف, Ministry of Justice, Ministry of Social Welfare, Education, Higher Education. All these people are actually included in the campaign. So the campaign is very comprehensive. It includes everybody. In every community, everybody will be engaged. So it's not just focusing on one person over another or on one generation over the other. As much as there are campaigns among grandmothers, there are also campaigns among young children at the level of kindergarten, using techniques that are suitable for every one of them. So I would say that I know that the campaign has been challenged by the COVID-19 lockdown, and the NCCW now is doing studies trying to document the impact of the lockdown that happened between March and July 2020 on the level of the practice, because we believe that it will probably have increased because the campaign was reduced. People could not do home visits, people could not do activities. And so it all depended on the impact of the previous campaign on the conviction of these people not to cut their daughters. And so it was a setback, but it was not a huge setback, because now we see today, especially, there are several celebrations across the country. Most of them are community-led by the Zero Tolerance Day, celebrating the achievements they have done in their own local communities. I think I'm coming to the last one. So we believe that Article 141 outlawing FGM is a major breakthrough. It will bring a lot of change to us, but it has to be integrated with the campaigns that are going on. It needs very careful introduction to the community, and it will not replace the community approaches that are being done by different groups. It will definitely be included within that. And now the NCCW is developing a communication strategy for the law, so that people would know. It has already been drafted, and the National Task Force, myself member in it, we have looked at it and we gave our comments, and this will be included in the recently drafted national strategy for ending FGM by the year 2030, which is being also drafted by the NCCW to be endorsed very soon, inshallah. I think this is my last slide. Yes.
Thank you,
So
Dr.
thank
Bedri.
you very much.
Thank you, Dr. Bedri. That was wonderful, very informative.
Very long, I'm sorry.
No, it was very informative. I have to say I've learned new things. I thought I knew a lot about female genital mutilation in Sudan, but I've definitely learned from your presentation. So I want to thank you again. I want to open the floor for discussion. I've been monitoring the chat, but I don't see any questions in the chat yet. But if you have any questions for Dr. Bedri or would like to discuss any of the topics in the presentation, please go ahead and either write them in the chat, or you can even open your microphone if you want to speak if you're on a Zoom. I have one question for you, Dr. Bedri. So in terms of the new law that's been proposed and now implemented, I believe, I think that, my worry is that it might push people more towards kind of like, backdoor, like backstreet, unofficial circumcision channels. So how do we make sure that that doesn't happen? I mean, every time, something is banned, right, by law, then people find ways. And I worry that these ways might even be more detrimental if they're done, in houses and in, not medically equipped locations. So what do you think about that?
I think that's something that it will have to deal with. It will happen. It will take place, and I think for myself, I was one of the people who were very cautious about having the law introduced. But I think now the campaign and the country is ready for the law for several reasons. One of them is the campaign now whether the Salima campaign, the Mawadda and Rahma campaign, or even just the pure FGM campaign, it has now reached almost everywhere. So everybody knows that this is a consensus that the government, the community, they want this practice to stop. It will come to the intelligence of people who are actually implementing the campaigns at the ground level. If people who are implementing the campaigns, they show the communities that this law is just going to make them stronger in protecting their daughters, then people will not be doing things behind, I mean, in the back doors. And I'm saying that why? Because in our medicalization study, several of the fathers told us this: if we had a law, then we would have been able to convince our mothers-in-law that we should not do this practice. Or if there was a law, I would have been able to convince my daughter, who's been constantly bullied, that this is something against the law and we are not going to follow your friends. So the law is not just something that it's not a whip that you're going to hit people with, but it is actually an empowerment tool. So if it's introduced as an empowerment tool, then people will feel, okay, this is something on my side. And that's why the NCCW till now is being very careful with partners in looking at the communication strategy of how this is going to be translated to local communities.
Yeah.
But it will happen.
I mean, I think that, you know, this discussion actually, there's a question in the chat that says, and I think it actually kind of builds on this discussion very nicely. So Saria says, would it be possible to know more about the law, especially convictions? Yeah, so is the law going to be more of, you know, I mean, and unfortunately that kind of happens with some laws in Sudan, right? That it's written, but it's not really, you know, implemented very strongly. Or is it going to be that, you know, very strongly implemented? You know, what are the convictions? Is it just a warning, or is it, you know, I mean, I think you said something about prison sentence too. So what is the general sort of?
It is a law that penalizes all forms of FGM, and there has already been one case that went to court. So and it is stronger in statement than the other state laws that has already been existing. So it's as I said, it came at a time when people were actually ready to uptake the law and make use of it. So as I said, we already had one conviction, and I'm not sure how far they went, but I think it was it was a husband who actually يعني, reported his wife and her mother and the midwife who took his daughter to be cut. So it will find some kind of resistance, and that's why, as I said, it needs very careful, because as much as people who want it to be implemented immediately, people also have to remember that you don't want people to hate it. You don't want people to go back and say, okay, you have a law, we are going back to what we used to do. And then it creates more resistance. So, but it is a very strong one.
Thank you. Yeah, I mean, I definitely celebrated that law when I heard about it. I was very happy about it. But as you said, you know, if it's not the right timing or the right language, it, you know, things can almost backfire. But I think, as you said, it is the right time, and we do need that law. Any other questions for Dr. Bedri? I don't think I see any from the chat, so I think we can move on to our next speaker. Unless anybody else.
I just want to apologize for having some slides repeated because I prepared my presentation last night and then I saved the wrong one. So I wasted 2 hours of work. So I had to repeat everything today. So I just apologize, Yani, for that.
No worries. Thank you for putting in all that effort. It was a very valuable presentation.
I just have a comment, if you don't mind, Afaf.
Go ahead.
First of all, I wanted to ask about the data. It's very interesting, the map. So the numbers in the east are much lower than Central and West Sudan. Kassala, Gadarif, and a little bit on the south side, Blue Nile is like a 68%. How do you explain that?
Okay, this has two explanations. One of them is some tribes in these areas, they were never actually practicing FGM. So it came to them by the movement. Even in Western Sudan, some parts they never practiced FGM before, but it came to them, and so it's by the dynamism of population movement with the Sudan, FGM was moved from one place to another. It was introduced. That's why there are this less percentages than the others. There hasn't been a lot of reduction, so that I can tell you it used to be 90 and now it's 60. No, I mean even the national prevalence is still 89. It used to be 92, so the reduction is very slow, but at least we're heading towards reduction. And that's why the issue of FGM and human and population movement are very important issues, because we recently did a report for the UNFPA, which was recently also published. We found that people sometimes, even if they don't practice FGM at all, if they have one or two practicing families in the camp, they will uptake it because it's a very appealing protection mechanism for many families on how to protect their daughters from any forms of sexual violence. So it's the issue of, so people in different contexts, they do it for different reasons, and that's why it is becoming a huge problem when there is a population movement. uh, in Sudan is one of them. It's a very good example of this.
Thank you, Prof. Nafisa. I think Prof. Ellen had a comment in the chat. Would you like to talk about your comment, please?
Oh, I just mentioned that I think, and I'll say something about this in my own presentation, that laws, really the best thing that a law can be is a deterrent to convince people not to do it. And they can be deterrents even without very harsh convictions or a lot of punishments if they have an excellent communication plan, and if they serve the purpose that Professor Nafisa mentioned of allowing a family to say, no, I don't want you to be circumcised because it's illegal, but also for other reasons. It becomes an added tool. And that's what I was convinced long ago when I was highly skeptical about the effectiveness of laws. My Sudanese colleagues convinced me that it was a potential tool. And now I find that this is also being touted in the United States and other countries as it can be used as a tool for deterrence. It doesn't have to only be about punishment. And if it can be deterrent, then you aren't as much at risk of people going underground or ignoring it as they did with the 1946 law, which was open to widespread distaste, and it was not involved in a social movement. It was imposed. So I think there's a very big difference here, and the timing seems to be right from what Professor Nafisa has told us.
Thank you, Helen, for your comment.
Okay, well, I'm going to introduce Dr. Greunbaum. She's a cultural anthropologist specializing in women's health. She studied Sudanese women's health issues for 4 decades, starting during the 4 years at the University of Khartoum in the 1970s. And she published The Female Circumcision Controversy, an Anthropological Perspective, based on her research. She has served as professor and head of the Department of Anthropology at Purdue University, as a member of the American Anthropological Association's Committee for Human Rights, as a researcher consultant for UNICEF in Sudan and Sierra Leone, as a speaker and an author. Her current project focuses on the process of change of FGC practices in Sudan. So without further ado, Dr. Greunbaum, you have the floor, and thank you for joining us. We're very excited to hear your presentation.
Thank you. Are you able to see my screen all right? This is new for me to do this. It's all right? Good.
Mhm.
Well, I wanted to say that I think culturally reinforced practices, which is what we're talking about here, can be very resistant to laws if the people do not agree with the laws or consider them to be imposed unfairly. And so I did want to mention, in the condominium era of Sudan's history, the 1946 law was very much imposed. And there was the Rufa'a revolution that people mention, where they rose up against the enforcement of the anti-circumcision law, but the circumcision law was a limited one then. It was the anti-pharaonic. As Dr. Nafisa has pointed out, there's been a lot of different laws over the years, but that one was in place for a long time. And Sonia Malik did a study back in 2004, a legal study, which showed that most of the, or many of the judges in the country had never heard of this law. There had been no cases brought. And if there were cases that came to the police, they were always dropped for reasons of not wanting to be involved in a shameful occurrence in the family, for example. But anyway, it was when Article 13 was taken out of that child rights law in 2010. I think the feminist activists and health activists and women's rights activists that I knew in Sudan at the time were so upset and became even more determined to bring laws to some of the states, and later as they were able to get it into the national government. So this is a big change that we've now been able to see this. I wanted to, as an anthropologist, I've had the opportunity to do research both in Sudan. I lived in Sudan for a number of years back in the 1970s, and I've been back many times for a month or two at a time, and been very grateful to work with people through Ahfad and the University of Khartoum, and in some of the communities in different parts of the country. And I worked with UNICEF Sudan, and I really appreciate the opportunities that I've had to do that. And so what I'm going to say today is based on my perspectives that have come from this work. And I thought it would be interesting for you to just see a little bit of comparison with 3 African countries and then 2 countries where immigrants have landed, to try to talk about how I see these issues playing out. One of the other countries where I had an opportunity to do some research was Sierra Leone. And this is a very interesting case because they have a very high prevalence rate for the practices. The prevalence rate is, I think currently they're saying about 89.6. It's tricky when you're looking at different sources of prevalence rates. I think people like Dr. Nafisa, who are working directly with the international organizations frequently, may have the most up-to-date information. I'm dependent a little bit on the published information that I can find. But in Sierra Leone, it was incredible how the rumors that, when I was there in 2008, we were hearing a lot of rumors about the fact that there would be a national law very soon. And many people told us, my research team traveled to different parts of the country and spent time interviewing local communities and doing surveys. And many people told us that they were going to hurry and get, if a law was coming, they were going to circumcise their girls quickly, or they told us about places where it had been done. So there's a tendency to want to resist a law that is not widely supported. And then there was also in Sierra Leone a very large backlash, because there the practices are embedded in an initiation practice for getting girls to be members of a Bondo secret society, which is a women's group that is very important in Sierra Leonean society. And so there was a huge backlash from the leaders of that social group, that it's a quasi-religious group, but it isn't. It's part of the culture so strongly that even Muslims, Christians, and people of other faiths do join it. So, and it has spiritual components. So it's a bit of a struggle to understand quite how it works, but the backlash has been very effective. There's been protests in the streets, and there were many legislators who we interviewed who were members of Bondo or members of the male equivalent, the Poro Society, who said, we will never allow a law to be passed. And indeed, they have managed so far to prevent it. Some of the activists, the illustrations here shows a Bondo ritual mask that is used. So there's a lot of artistic and ritual elements to the initiation. But the Sierra Leonean women are free to choose slogan is what the circumcisers, the Bondo leaders, have been using. And as you can see, this is a very interesting kind of thing when you see people co-opting freedom of choice as a slogan to continue a practice. And anyway, so far there is no law, but nevertheless, it's very interesting when you look at the maps of different prevalence rates by region, you can see that there is a great deal of variation in Sierra Leone. It's not low anywhere. It's still the lowest is about 75.6% over in the Western area, if this is up to date enough data. But this is what we found in our in our research was that even without the law, the rates are very high, but they have begun to come down a bit. I think that's probably due not to the law, which they don't have, but rather to all the other activist ways that people are doing to try to bring this down. The trend lines that I was able to find on the website for the organization 28 Too Many, which has tried to use the DHS mix and other UNICEF published data to make trend lines that are based on the idea of showing the prevalence rates in the different age groups as a way of trying to say, if it occurs at the age of, in Sierra Leone, it occurs a little older than in Sudan, more like between 12 and 15, and in the past it used to be even older. But you can see that the trend line for the younger age cohorts is noticeably dipping, which suggests the ways in which other factors, in addition to laws, are extremely important in making changes happen. Now let's look at Kenya. Kenya is an entirely different situation because Kenya had laws from 2001 and then even a stronger, more explicit anti-FGM law in 2011. And they have had a long history of both colonial efforts, which were resisted in the past, as was the case in the early efforts in Sudan. But later, there came to be a lot more variation between ethnic groups and a lot more interest in and acceptance and leadership. And they've had numerous rituals over the year. You've probably heard of their alternative rituals without cutting. And they've had shelters for girls to run away if they think their parents are going to cut them. And they have educational curricula. And one of the things I found very interesting was meeting leaders. I never met the woman pictured here, Leah Chebet Pasia, but I did meet a couple of other leaders, Susan Chebet, for example, in the Kalenjin region of Kenya, where they were very consciously revamping the traditional practices of their cultural groups to encourage people to see that initiation without cutting could still reinforce social values. Their girls would still be moral and helpful and identify with their origins, even without cutting. So as a result, Kenya has had certain ethnic groups. If you look at this regional chart, you can see that the area with the highest rates is the area closest to Somalia. So these are people who are ethnic Somalis very often. So there are some ethnic groups that hold really strongly to it, other ones that have reduced dramatically. And in fact, there are some areas where some ethnic groups, the chart on the right shows specific ethnic groups. It's kind of hard to see. I copied this from a presentation from a webinar I saw presented some weeks ago, and it shows that some of the ethnic groups have been very resistant to change, like the Somali ethnic group, but some have been very fast to change, and they have reduced the incidence almost to zero for some of the groups. So I think this is a very exciting thing to see, that once a downward trend has some traction, there's a way that it can accelerate. And that's something UNICEF has theorized for years, but we're now seeing some evidence for how that works in places like Kenya. But again, Kenya did have a law, and the law has been very useful in some of the activities, like the shelters for girls, et cetera, and trying to educate parents about the need to change. If you look at a comparison, then you can see that both Sierra Leone and Kenya have had pretty dramatic reductions in a 30-year period, but it seems to be really accelerating, I think, more in Kenya. But this is something very important to do. As Professor Nafisa mentioned, the overall prevalence for a country can decline only very slowly, because all the women who are cut remain in the cut portion, and it's only the incidence of the new cohorts that begins to change the statistics. For Sudan, you've already seen this map, but I wanted to mention something about how my work as an anthropologist has contributed to my thinking on this. I had the opportunity to work in several rural areas since the 1970s, and one of the people that I came to know very well was this woman who is the trained midwife in one of the communities in the Jazeera where I worked. And I've gotten the wonderful opportunity to see her do her work, delivering babies and doing circumcisions back in the 1970s, and then see her work over the years. This photograph was taken in 2004, and I most recently visited her in 2016, I believe was the year. And she is somebody who over the course of her career has made dramatic changes in her attitude. Now, you may not think it's dramatic enough, because we'd like people to change their opinion immediately. But if you think about the social context that many rural women found themselves in back in the 1970s, it was not an easy thing to contemplate the changes that now are being proposed and have so much more widespread support because of all the work that's gone on for the last decades, and now with a new law. So you can see these different areas have different frequencies, but she is from the Jazeera area, where it was 86.9%. But the prevalence rates in Sudan have been much slower to decline. I think we'll see an acceleration in the near future, now that there's been this fundamental work of spreading so much. My main argument in all of my work on circumcision is that change is most likely to take place when you use a multifaceted effect, not just laws, not just health education, but the wide range of social marketing and media, leadership, religious education, et cetera. So if we just look at the three countries, we can see that Sudan is the slowest. That's probably because it was the highest, it was most culturally well embedded, and also the different ethnic groups in Sudan did not have different practices as they did in Kenya. So in Kenya, it could be addressed in different ways. So my question, or my work has been, how did Sudan manage to decline 10% in 30 years? And I do think it's been a very large number of types of activities that are responsible. I was very excited when I was in Sudan in 2004. I worked with UNICEF on a project where we looked at several different parts of the country. And one of the recommendations we came up with was, we felt like a lot of the negative messaging that had been so prominent in the 80s, 90s, and onwards really needed to be supplanted by the positive messaging that a few of the groups were trying to do, and particularly the idea of trying to have positive words for to enable people to see non-circumcision as a positive thing. So that's why the whole movement about developing the concept of Salima, developing Salima marketing, something that that Samira and Ahmed was very involved with in UNICEF, and Ahfad University was very involved with in the local organizations it worked with. This became something that I think was very helpful. So now the midwife that I mentioned earlier, she now has completely, as of about, let's see, what year is it now? Nearly 10 years now that she has pledged to not do any more circumcisions. She had moved over time toward, with religious influences, medical influences, and social influences, toward wanting to reduce the severity of the circumcision she did, until moving to completely eradicate it. Afaf, were you giving me a time sign there or no? I can't hear you.
No, it's not a time sign. I was trying to share it on Instagram, but
okay. But do warn me if I've gone on too long. I'll try to complete my thoughts quickly. But I think she told us about how in her community, because there began to be so much pressure against it, and because she began to have better understanding, she determined and took the pledge not to ever do it again in any form. But a few of the families still wanted their daughters to be cut and found ways to do that. But once they began to discover that anyone was trying that after the midwife quit, they quickly shut that down, and the whole community came together. And I think that's the really important lesson that a lot of the change efforts has been trying to do, is to get that social support, that reinforcement, so that conformity becomes conformity for the change, not conformity for the practices that were done before. And these young women that I interviewed, they're determined not to do it to their daughters. So they have the attitude well established. So in summary, I think having religious leaders involved, using Salima, you see here a picture of Samira. I have a picture of a group from Kordofan, a singing group. We have pop culture, the Salima ambassadors. A lot of these things are from several years ago, because that's the last time I took some of the pictures. But I think it's important to know that that is having an effect, and probably is also part of why it's possible to even have a law. So in summary, about countries of origin, where cultural norms strongly support FGC practices, it can be very difficult to enact or enforce a law against public sentiment. But I do think that Dr. Nafisa's example of how you have a good communication plan and have it as part of a bigger process of change is very effective. Now, in other countries, let me turn for a moment to the global north, because there are many immigrants, as you know, living in the United States, in the United Kingdom, in Sweden, in Norway, etc., and in Australia. And so what happens to those situations about the laws? It will be very interesting for us to hear more about that in a moment. But one of the effects of this is that the law that tends to be set up is about enforcing a law on immigrant populations. So it has an extra problem, because it risks exacerbating anti-immigrant sentiment, anti-Muslim sentiment, anti-Black sentiment. It has a tendency, it has a risk of being enforced or designed in a way that seems racist. So we have to be very cautious about the enforcement to make it have the positive effect that it's desired to have. So let me just give you a couple of examples. In Sweden, the enforcement can lead to unequal treatment. And Sarah Johnsdotter has done some excellent research where she's looked at legal cases that have been brought. If you look at how few cases were brought in Sudan, you should look at how many cases were reported to the police in Sweden. She said she told me yesterday that it's up to about 200 cases now that have had police reports. But at the time of one of her recent publications, there were 122 cases. And of those 122 cases, most of them were thrown out. This was like overzealousness from the community saying, oh, this woman is from Somalia, I think she circumcised her daughter, when really there may have been no evidence at all. And sometimes it has led to unconsenting genital examinations of girls. Sometimes it has been, resulted in detentions of parents who had no involvement in and were deeply opposed to female genital cutting at all, but they may have been arrested because of a suspicion by a medical or social services worker who really didn't know either how to judge what genital appearances, how they might vary, or because they were simply worried about the publicity that says that, oh, it's going on all over the place, when in fact it probably isn't. Other anthropologists who know the immigrant communities in those countries say the cases are actually very, very few, because most of the immigrants do know about the law and have accepted this. Now, that's not to say there might not be cutting on trips back home, and that's something that the legal structure always also is trying to prevent. So I should say the proposal for improvement is that expertise of medical personnel is really important here, and reducing the prejudicial expectations of care and social care, healthcare and social care providers is really important here, so that the cases that are brought forward will be ones that will be helpful in the overall goal of being deterrent for others. In the United States, you're probably familiar with the fact that there was a big brouhaha over the last couple of years over the case of a pricking or scratching technique done by the Dawoodi Bohra doctor in Michigan, Jumana Nagarwala, pictured here. And as a result of that case, a lot of people were it really muddied the waters for laws, because it sounded like, well, maybe she's doing less than other people were doing. And yet others have said any sort of medicalization, any sort of procedures is going to give it legitimacy, as Professor Nafisa said. So it needs to be fought. So this has been a really interesting discussion in the United States over the last couple of years. The result in this particular case was that the federal law, which had been in place since 1998, was thrown out, struck down, and the judge said laws have to be made in the states that govern the state situation. And so if you look at the state laws in the United States, it turns out there are 11 states that have no FGM laws at all. And the other ones have various levels of severity or clarity, shall I say. So, and again, I think that if our goal is deterrence, the really key thing is to have improvements in education for health and social care providers, to better outreach to immigrant communities, so that this can be done. And we know there's a couple of really wonderful health centers that have been doing a lot of work in research and in providing better health care. One in Arizona, one in Boston. These are very important developments. But there are many parts of the United States where there are either so few immigrants that doctors aren't familiar with how to care for a woman who has had a procedure earlier in her life and now needs medical care later in life. And I think that's really important, that we find ways to address that, whether it be for clitoral reconstructive surgery, if she desires that, for defibrillation, or for whatever additional care might be necessary during labor and delivery. So I just wanted to close with saying something about how I feel like it's very important that we encourage empowerment. And that includes empowerment for all the many women in the immigrant situations in the diaspora who are living with past cutting. They should not be shamed. They should not be subjected to the kind of messages that sometimes happen in the effort to get people to stop cutting. They say how terrible it is, and that can result in a very harmful attitude toward African women living in the diaspora. And I would encourage those who are in the diaspora and those of us who are in the countries of the diaspora to find ways to work on deterrence that does not result in shaming or pitying and horror and all the kind of things, condemnation that has been reported. My friends Lucrezia Catania and Abdulkader and Osman Abdulkader and their daughter Jasmine Abdulkader, this is a situation that they've been talking a lot about and encouraging a way to say, look, a woman who has had a circumcision still has most of her clitoral tissue intact, still can enjoy sexual pleasure, still can benefit from therapy. So we need to have a more positive attitude that encourages a pride and empowerment for women living with that. And they then, in turn, can also be very positive educators for change, for giving up the practices in the new countries. So I do think this organization, I came across their website. I heard about it while I was in Italy the year before last. It's an empowerment group for circumcised women in European countries. That sounds really exciting. They contribute their own art. It's a lot of people are involved in it from different countries, and in I think France and Italy and various other countries. I don't know if Afaf or I don't know if anyone has been familiar with this, but I'm interested in hearing more about that too. So I want to thank you for your attention to this talk, and also thank all the colleagues and organizations that have enabled me to have some of the insights that I have. Thank you for your attention.
Thank you so much. I actually did not know about this organization, but mentioning the diaspora actually kind of leads to our next presentation, which is from a young member of the diaspora in Europe, who's also leading efforts there against FGM. So I do agree with you that, the diaspora has a lot of work to do, and the challenges for the diaspora are different from the challenges in Sudan and kind of require a different set of skills. So again, thank you for your very informative presentation. I really enjoyed it. I think there was one comment in the chat from Haifa and Nugud Said. She said that obstetrics and gynecologists can play an important role in the prevention and care of FGM, including FGM medicalization, because they are respected and can act as change agents and active advocates. Thus, it is important for us to have the right knowledge, skills, as well as a shared attitude towards its abandonment. And I completely agree with that.
Excuse me, may I comment? Also, I've talked to a number of well, particularly doctors in Italy are some of the opportunities I've had to talk about diaspora situations with the role of physicians. And one of the things that's really tricky for physicians is that they're able to be very influential on their patients' lives and encourage how their patients, like if for a gynecologist obstetrician, she can talk to a woman who's giving birth about, oh, your little baby is born now. We're going to let's protect her as we go forward. I mean, they have a role to play in messaging and in really helping if they can talk to people in such a way that is not condescending, it's not horrified, it's not shocking. And that's something Lucrezia Catania has been very good at in Italy. And she's concerned that laws that are too strict, that require mandatory reporting from physicians and overcome the physician's opportunity to maintain confidentiality might interfere with that. So she wants her clients to be able to tell her, you know, I'm thinking of getting my daughter circumcised. What do you think I should do? She wants to be able to work with them rather than having to report them to the police who know nothing about it and might do something more drastic. So I really appreciate that comment from Haifa. Thank you very much.
I mean, I think just adding to this diaspora issue, I think
Yeah,
there's sorry, was somebody trying to?
Nafisa?
Hmm?
Nafisa wanted to
and
say,
me, I just wanted to, yeah, I just wanted to follow up on Haifa's comment and Ellen's comment. And I think Ellen put her, as they say, her hand on it, that in the context of Sudan, and I think also in other developing countries, the medical doctor usually does not engage in the delivery. It's usually the midwives.
Mm.
And the doctors, they are just around just as supervisory people. And the power there is for the midwives, even within the hospital. And that's why we see our level of medicalization is very high among trained midwives rather than among doctors. I'm not saying that obstetricians and gynecologists cannot play a role. They do play a role, but the problem is it has to do with the power relation between them and the midwives. And because the people, they know that at the community level, the say goes back to the midwife, and at the delivery level, the say goes back to the midwife. So so the doctors, it's not only the obstetricians and gynecologists, but also the pediatricians. Because if they are the people who meet the parents with the child, they are the people who can say, please also when you take your daughter to immunization, please remember not to do this. But usually, if I'm going to a gynecologist or obstetrician, I wouldn't take my daughter, and I don't think he or she will have any reason to discuss with me the circumcision state of my daughter, unless he asks me or she asks me, and then in that case, it depends on whether I think this is their business or not, because in the mind of many women, especially here in Sudan, this is a midwife's issue and this is a women's issue. So the doctor has to be very intelligent in
yeah,
order to be able, and very motivated
and that's why
in order to do
that's
that.
why training is so important, and it should be handled
Yes,
by people who understand it well, not by police. In
Yeah,
my
exactly.
I
And
think
that's why I wanted to say it has to go into the curriculum, because surprisingly, in our medical curricula in Sudan, there is nothing about FGM there. Now that I know the obstetrician and the Society of Obstetric and Gynecologists in Sudan now are developing a curricula on FGM so that it can, through the Ministry of Higher Education, be included in all medical students curricula across the country, because they don't know anything about FGM. So when they come out, all they know is the little they learn when they were working as volunteers in some associations.
yeah,
So, and this is where the gap is.
interesting.
I,
The other thing about education to gynecologists is, one situation that could happen, especially if the heroic type of FGM is very, it's very mutilating, basically. And when women come to European countries or America, and they have deliveries here, childbirth, I think that is a very distressful time for them. And I've heard about this from actually people who I've met in the United States, where the gynecologist has never seen, the obstetrician has never seen somebody with that anatomy. And then they end up with birth complications, they end up with stigma. It's very traumatizing. So they've had trauma in the past in their countries, and then they come here to give birth, and it's even more traumatizing. So
and
education.
Afaf, if I might add, also nurses play a very important role in that, and also daycare providers. Often, John's daughter mentioned this in Sweden, is like even people changing diapers of young children in a daycare center may say, oh, she's an African child, she looks different, I bet she's been circumcised, and it can lead to unfair suspicion. So a lot of people need training, and training not to overreact, but to just be caring and more oriented toward education. I think we must leave time for Saria.
Yeah,
I'll be
yeah.
quiet.
Okay, so last but not least is Saria Nageeb. We are very excited to hear from her because she is a young person in the diaspora, so a different perspective. So Saria has been campaigning and working on issues of gender-based violence with a focus on Black and minority ethnic communities for the past 10 years. She worked at NESTAC and helped to set up the first Greater Manchester-wide support service for girls and young women affected by FGM. Prior to that, Saria was the policy officer on FGM at ROSA, the UK Fund for Women and Girls. There, she supported the conclusion of the Tackling FGM initiative, including conducting research with FGM organizations across the UK, and has developed a best practice guide for FGM community engagement. Saria's work on gender-based violence has predominantly been with young people, where she has coordinated both national and European youth projects to train and develop young people to become active campaigners and youth advocates on the issue of FGM. In addition, she has also developed several resources on FGM, including a secondary school lesson, which has been PSHE accredited. So very impressive, Saria, and I open the floor for you. Go ahead.
Brilliant, thank you. I'll just pull up my presentation. Right. Has that come up for everybody? Fantastic, brilliant. So I wanted to say thank you so much to Sama for inviting me to present and to speak. And I'm really honored to kind of be speaking alongside both Professor Ellen and Professor Nafisa. What I wanted to cover in my presentation was to kind of drill down specifically on the FGM campaign in the UK. So I'll sort of do an overview on the legislation and policy changes, and you'll have to excuse me, I find sort of legislation and policy really fascinating, so I might kind of go through the different iterations of law that we've had in the UK, and then sort of look at community-led interventions, and then just talk about a youth-led campaign within the UK. So we've probably in the UK had kind of the opposite problem to countries of origin and like a country like Sudan, where we've had a lot of campaigning from FGM affected community members to have legislation and to have policy, because what we were seeing sort of for a very long time was professionals really who should be responding, such as healthcare professionals, social workers, just sort of turning a blind eye and saying, well, this is an issue that affects Black and brown communities. We really don't have to deal with it. And then the challenge with that is that then resources, support services were not being funded. So in terms of kind of data around the UK and prevalence, so it's estimated about 137,000 women in England and Wales might have undergone the practice, and about 60,000 girls under 15 at risk. So this data is from 2015. It's based off of the UK census data of 2011, and then they base it off of the UNICEF data from countries of origin. So it's really kind of far removed in terms of actual real life data, but we use it in the UK as a starting point to prove that FGM is an issue in the UK, and it should be resourced and it should be funded. More recently, I'd say within the past 5 years, they've been recording actual cases of individual women who are accessing healthcare facilities to be able to give us a picture of how many real live women are affected by the practice. And the Department of Health in the UK kind of records that, and they produce quarterly reports. So what we found in kind of the most recent data, so that's April 19 to March, no, that was the last year's annual, we had about 6,590 individual women who had FGM and attended a hospital appointment where it was relevant to ask them about FGM. And we're seeing roughly quarterly about 1,500 women and girls accessing healthcare services. So we know it's still a growing issue in the UK, and there's no specific local authority in the UK where FGM isn't an issue. So the FGM law, we initially started having legislation in 1985, and I know the panels were the kind of 10 people who were speaking were mentioning that women were coming from FGM affected communities, delivering in diaspora countries, and healthcare professionals had absolutely no idea what to do with them. And that was definitely the case in the UK. Women with type 3 or infibulation would present, and midwives, doctors, OBGYNs would have no idea. It led to a lot of women having to have emergency C-sections, lots of tearing. In some cases, we've spoken to women who were sort of made to be a spectacle or a sideshow. They'd bring medical students to look at them and take pictures. So that's probably where kind of the initial 1985 law came into place. At that point in time, it was still called the Female Circumcision Act. It didn't matter if you did it outside of the country. It was only illegal if you performed it in the UK. And we didn't have any successful prosecution. Interestingly, with the UK law, and this kind of carries on, is you're allowed to have procedures for medical reasons. And within medical reasons, they include mental health. So it creates a loophole for what we would term as designer vaginas or female genital cosmetic surgery. So if somebody presents to their GP, presents to a healthcare professional and says, the way that my genitalia makes me feel uncomfortable, has some level of body dysmorphia, you're legally allowed to have that procedure in the UK. But if you presented and said, well, I want to alter my genitalia for cultural reasons, that would be illegal. So we're already starting to see a double standard in UK law. The UK law was revised in 2003. The main kind of revision was people, advocates and campaigners were saying a lot of times people who wanted to perform FGM would just travel to country of origin, have the procedure done there, and then come back to the UK, and the law didn't apply to them. So they added extraterritoriality. And it's one of about 2 or 3 UK laws that will prosecute someone even if the crime took place outside of England and Wales or the UK. They extended the penalty, so now it goes up to 14 years in jail and or a fine. I think also very interestingly, the law defines a girl as a woman. So basically you can't get to like 18 or 25 or 36 and consent to have FGM in the UK. It will always be considered illegal to practice it. So that varies, because I know some European countries and some legislation in America, once you're 18, you're allowed to do whatever you want to your body, including having FGM. That's not the case for us in the UK. And then the law also only covered British citizens and permanent residents. So we were seeing a lot of people coming to the UK, let's say on a student visa, on a work visa, very explicitly saying they were going to perform FGM on their daughters, and nobody could really legally stop them from doing that. And we had sort of conflicts between safeguarding legislation or protecting children versus immigration legislation in the UK, and kind of immigration, sadly, always won. So again, lots of campaigning wanting to revise the legislation. And in 2015, the UK changed legislation through the Serious Crime Act. So what they added was they extended extraterritoriality. If you are seen as a habitual resident in the UK, that law applies to you. So that got rid of that loophole of people on student visas, temporary visas, saying they were going to have their daughters go through FGM. They also put in civil legislation. So we have FGM protection orders. These are modeled off of forced marriage protection orders in the UK, because the two topics tend to be combined quite a bit. And it basically can prevent a family from traveling out of the country, or it can say that they need to have specific things in place if we suspect that they might be at risk of FGM. They're also really useful to bring people back into the country who are at risk of FGM. So I was working with a young person whose family took her to country of origin forcibly. There, they were telling her she needed to get married, she needed to have FGM, and she didn't feel safe there. She was getting a lot of abuse. So we used an FGM protection order to say she had to be brought back into the UK, and she had to be presented at court so that we could assess whether or not she was at risk. So it's a useful bit of legislation that doesn't criminalize people, but allows some protection for women and girls who want it. The other challenge we were finding with UK prosecution was we'd get a case of FGM, mum would say, it wasn't me, it was dad, auntie, grandma. Dad would say, no, it wasn't me, it was mum, auntie, grandma. It was very hard to pinpoint which parent or guardian knew about FGM. So they've added in parental liability. So if you are a parent of somebody under the age of 16 years old and they undergo FGM while they were in your care, you could face prosecution for up to 7 years. And the way that that's been kind of messaged to community members, because we did have cases where parents might travel to country of origin, they leave their children with grandma or they leave their children with auntie, and grandma goes behind their back and performs FGM on their daughter. So we then started placing more onus on parents. So if you are traveling to country of origin, you need to know where your children are. You need to make sure you're actively safeguarding and you're actively protecting them. So that's sort of where parental liability came in. We do have multi-agency guidance. So that's guidance that explains to social work, police, teachers, how they should respond to FGM. And for a long time, it was a piece of paper that nobody ever read. Nobody received training. Nobody knew anything about it because it was seen as a small marginalized problem and we don't have to care about it. So they've now made this guidance statutory. So they have a legal responsibility as professionals to know and understand how to respond to FGM cases. They can't see it as a fringe topic. Very controversially, I think they've added mandatory reporting. And I know within the discussion there were, I think Ellen yourself had brought up, they've got mandatory reporting in Sweden. So we've got a similar policy in the UK. So how mandatory reporting works is it's only eligible for health and social care professionals and teachers if during the course of their everyday work, they know that somebody has had FGM, the child has had FGM, or a child discloses to them that they've had FGM, they need to report that to the police. When it first came out in 2015, 2016, it created a lot of uproar. And what we were finding was nursery staff, for example, actively looking for FGM and looking at people's genitalia. Teachers felt like they had to actively ask students. So we had to spend some time clarifying that really the reporting only follows through if you're doing the normal course of work. You're not supposed to look at people's genitals. That's a violation of a whole nother part of people's human rights. It's just if someone tells you they've had FGM, you then need to do something. Because we were trying to find that balance between some professionals turning a blind eye to it, because that's what was happening, and then some professionals kind of being overly zealous about it, and try to find that middle ground. And then the last bit of legislation they added, which is anonymity for victims of FGM. Interestingly, that's only anonymity in the press. And I remember when this first came out, I took a group of young people to UK Parliament to talk about the changes. And a lot of the young people I was working with just thought that was a pointless bit of legislation, because they were like, but your parents are going to know you reported them. Your aunt's going to know you reported them. Like, who are you protecting people against or people from? And then the last bit is mandatory recording. So recording is where we're collecting data, and that's primarily healthcare professionals. If women come to them, we now have like a specific tick box that says FGM, because previously in the UK there was no code for FGM, so there was no way of tracking if a woman had had FGM, whereas now, particularly during midwife antenatal appointments, one of the questions they will ask is women around whether they've been cut or had any procedure or alterations to their genital region. And usually the ideal is for them to explain that that's to be able to facilitate healthy and safe delivery, as opposed to just to penalize them. And usually it's embedded within questions around domestic violence anyways, and should be done in a safe, confidential way. So that's sort of kind of legislation and where our latest bit of legislation is. So we did have our very first conviction in March 2019. And that was a 37-year-old mother was found guilty of cutting her 3-year-old daughter. So mother, interestingly, was from Uganda, which really isn't known as a heavily practicing FGM affected community. Usually with Ugandan communities, you hear about pulling or FGM type 4, and then father was from Ghana. Interestingly, father was not charged. The way that this came to healthcare professionals or came to the wider public was that the child, the 3-year-old, had extensive bleeding from her genital area. The family then called an ambulance. She presented at hospital. When asked about it, mum said, oh, she was reaching for some cookies and then fell down and cut her genitals on a ledge. And it just, none of her stories matched up, which is why the CPS moved forward with it. Again, thinking back on some of the conversations you were having, Ellen, about the narrative, reading through a lot of the articles, very, very stigmatizing language. In the UK, we're still trying to work against it being called barbaric. It gets linked a lot to like witchcraft. And then I think it further highlights or exacerbates BME tensions, Black minority ethnic tensions within the UK, because it's just another thing that Black and brown people do because they're not nice or they don't like their children. I remember when I was working for an FGM organization, we got approached by the BNP, which is the British National Party. So that's like extreme right-wing government party, was like, can we support you on the FGM campaign? And we were like, no, because you're anti-immigrant and anti-Black and don't align with anything we're doing. We can see sort of that rhetoric as well. And we've had 3 other FGM trials where people were found not guilty. The first one, interestingly, was a medical doctor who was part of an FGM specialist clinic who got training on FGM. A woman came to deliver. She had type 3, so she was fully closed up. He had to reopen and then did some form of stitching to stop bleeding. That had happened previously. In 2015, there was like a revival of the FGM campaign, and the CPS started looking at old cases, and they suddenly decided to charge him. So it created, I remember I was delivering training to medical professionals when this came out, and there was a lot of fear amongst doctors, medical professionals, because we didn't have that guidance of what is stitching to stop bleeding and to save someone's life versus what is stitching that's considered FGM. And since then, the colleges here have produced a series of guidance, and he was cleared. We then had an odd case where a father was charged with saying that he'd subjected his daughter to FGM. She disclosed to a friend that because she stole money, her dad then arranged for a person to come to her house and cut her genitals as a form of punishment, and that this had happened on 2 separate occasions. So this young person told her friend, that friend told her mother, the mother then called authorities. And then it turned out within kind of the trial that basically mum and dad were separated, and there was some concerns about whether people were fabricating allegations against each other within this wider custody battle. And I know for myself working on FGM cases, we've definitely had that come up, where people will lob these kind of accusations around FGM in a tit-for-tat wider family feud. The last case was an interesting case. So that was in Bristol. We had an FGM activist from a well-known FGM organization in the UK. Apparently that activist had heard this father say in a taxi ride, oh, I've had my daughter go through a procedure. It led to kind of, I think, like a year where they were looking at it and investigating. The girl was medically examined the first time, and they felt that she had FGM, and then was medically examined a second time by a specialist who then stated that she did not have FGM. So that got thrown out of court. And again, we saw that tension between, I think some campaigners in the UK were like, we need to have a conviction to show that the law is effective. But then it did lead to, for me, I think, some overzealous sort of charging, because we saw it with these 3 cases being thrown out. So in terms of kind of then implementation, in the UK, they take sort of a local authority approach where each area has to then, you have to sort of build enough evidence for a local area to say FGM's enough of an issue here for them to invest in training, resourcing, and providing support. So there's still a lot of challenges about where does FGM policy sit? Who's responsible for it? How do you train your professionals? So I know when I moved up to Greater Manchester, there was just so very little services for women and girls who were affected by FGM. And we had to keep making the case that as a doctor, you should be trained, as a teacher, you should be trained, because there's X number of girls involved. We do have some national support within the UK. We've got an FGM helpline. There's the National FGM Centre, so they offer resources, training, policy. And then there's a government FGM unit, which primarily works on policy. It doesn't do a lot of case management. In the UK, I'd say the FGM campaign's primarily led by health. It's seen as a public health issue more so than a safeguarding issue or a violence against women and girls issue. So we do have specialist clinics. So they offer medical examinations, because not everyone can do them. And they offer the de-infibulation. So that's the procedure to reopen women who've had FGM type 3 and allow for like sexual intercourse, vaginal delivery. So we've got 8 clinics. They're less than they were 5 years ago, concentrated in London, which is seen as where a lot of BME people are. And then after a lot of fighting and campaigning, they had a youth specific service, because they were mostly linked to maternity and antenatal services. And we were trying to make the case, why should a 16, 15-year-old have to wait until she's pregnant before she then gets access to medical services? It's really important we cater to young people. We're seeing a growing number of emotional and psychological support services for women. Not enough, but it's getting there. And I think for women who've undergone FGM in the diaspora, you have both the trauma on one hand, but on the other hand, you've got like how it gets stigmatized by the community you're in. So hearing rhetoric about like, oh, you're damaged, there's something wrong with you, hearing rhetoric about like you're barbaric, but that plays a role, I think, for individuals who go through FGM. Within kind of children's social care, they've started to develop some tools, because what we were finding was social workers had no idea how to speak to anybody who'd gone through FGM, and either would then avoid the conversation or come down in a really draconian way. And they were somehow expected to implement and risk assess, but they had no framework to do that. So we've developed resources to do that. The police also controversially do an operation in UK airports called Operation Limelight, where they target flights that are primarily going to countries of origin. And then they will speak to people who are boarding those flights and ask them about FGM. They'll ask them about forced marriage. They'll ask them about modern slavery, sometimes terrorism, because all those things are lumped together. You can probably tell from my tone of voice what I think about that operation. We were part of, one of the times I was working, we were part of Operation Limelight and had a lot of feedback. They didn't provide interpreters. It primarily was an exercise where you were looking at who looks like they're not from the UK. Are they black or brown? Are they wearing a headscarf? Go speak to them. you're doing it in a public space. Sometimes you're talking to women with their children there. It just was a really inappropriate, I thought, exercise. But I think there was a pressure on the UK government to show that they were doing something. And then I think for me, one of the most useful things was within schools and education establishments, relationship and sex education is now finally compulsory. It became compulsory last year, 2020, and FGM was specifically mentioned in the guidance. So sort of I wanted to kind of slightly switch frames towards community engagement on FGM. So I'll ignore all the policy and legislation side. We had the Tackling FGM initiative. So that was a 6-year initiative. It was just community-based. We had 51 community-based organizations that we funded who did a range of things. So they did a lot of outreach, community awareness work. They developed resources. They did casework. And really, they were kind of the driving factor because they started 2010, finished 2016. They were the driving factor for changing a lot of the policies and legislation. So that was sort of the number of people that they reached. And what it's led to was the idea that actually you need to have community engagement in order to change FGM because it is a social norm. Just having a law is not going to be sufficient. Just having sort of social workers who are not from that community like tell off people and go like, you're not supposed to do it, is not going to change things. Having police at borders is not going to change things. Because fundamentally, like where there's a will, there's a way. It just drives the practice underground. What we need is to have community members involved so we're tackling that will or that drive for FGM. And I think similar to what Professor Nafisa has shown was the biggest change factor was women from FGM affected communities who recognized it as harmful were changing things the most. Like that was the biggest protective factor. And that shifted the model so that now, as opposed to removing children from their parents, because that did used to happen in FGM cases, they would just remove all the children, including the boys in one of the cases I worked on. They now work at strengthening awareness with parents, with mum and dad, and who else is in that family home to make them protective factors, as opposed to just looking at them as potential perpetrators and punishing them. And the sort of from the research we found, there is a lot of evidence and a lot of individual community members who feel like they're more willing to engage in the campaign if that's the way it's done. Because I think we're also in the UK where there's a hostile environment to BME people. So in terms of kind of young people on FGM, when I first started working on FGM in 2010, it seemed like a ludicrous idea for young people to be involved. A lot of the material and the resources was targeted towards adult women, particularly adult women who were pregnant or adult women who were going to give birth. And to me, that was very frustrating because I felt, well, FGM happens to girls and happens to children. Like, you know, the average age is 5 to 8 years old. Why are we excluding these people from young people from the campaign? So we've seen sort of probably 2 really large organizations working on it. Forward's youth program developed a lot of work in schools and have different lesson plans. And then Integrate UK have created a lot of videos and resources for young people as a way to raise awareness. We probably saw the height of it in the UK at the Girls Summit in 2015. So that was an international summit held to end FGM and child early forced marriage, CFM. And from it came Youth for Change, which was a global kind of network of young people, young youth advocates. It was in the UK, Bangladesh, Tanzania, to try to tackle FGM, child early forced marriages. So Youth for Change kind of, they developed and initially kind of did a scoping research and found there was a need for more young people to be part of the campaign. But there was also this wider challenge of how do we get young people accessing policy spaces, accessing kind of the Home Office, accessing ministers to be able to implement. And then the other part that we saw was we needed schools and education establishments to be safe spaces for young people. so that they could access support, they could make disclosures, and teachers knew how to robustly respond to that. So Youth for Change in the UK felt that was the campaign that they wanted to tackle. They developed sort of Train to Protect. That was the slogan of their campaign. They met with a variety of education ministers. They met with the Equality Minister, kind of presented at various Home Affairs Select Committees for a couple of years, and piggybacked on a wider campaign that was happening about relationship and sex education. And as I mentioned earlier, in 2020, the campaign was a success because finally, after 10 years of advocating, sex and relationship education now is compulsory in all schools. They must teach it. And we managed to get FGM, child early forced marriage, incorporated into that curriculum. And so it means more young people hopefully will have that awareness raising kind of potential, and also know how to access support. So that's a really quick kind of whistle-stop tour of the UK campaign on FGM. I will attempt to figure out how to stop sharing. There we go.
That was wonderful. Very, very impressive. And I've learned so much, honestly. I think the US lacks such, laws and efforts and campaigns. So your experience is, one to be taught and learned from for the diaspora and other parts of the world. So that was really impressive. I think we have multiple, discussions in the chat. I can go through them. I think Ellen, mostly from you, I think, one of them that I think is impressive is the at-risk idea. So you're talking about, surveillance. So feel free to share that idea.
Yes, I think we often see the statistics on how many girls are at risk, but the way they determine at-risk statistics is basically by ethnic identity. If you're from an immigrant family or of an immigrant ethnic group, you get labeled as at risk. And we're very concerned about this kind of, those of us who have been talking about how do we overcome the racism implicit in a lot of this without, losing out on the goals. And I think the points that Saria made about the surveillance at airports, that Operation Limelight, those are precisely the kind of things that we're afraid of. You certainly don't want girls being taken abroad for FGM, but by the same token, you don't want families having their children taken away or having the really drastic measures that harm those that are supposed to be helped. So there has to be some way around it. And I think it does require a really fundamental challenge to the way journalists talk about the practices, and even the way we activists might talk about them, because we have to be careful not to make it sound like like it's something that you must stop this at all costs for everybody, even if it means the genital exams of every girl in the daycare center. That's ridiculous. We have to be more measured and more wise about how we do it. And I think, Saria, you've given us some excellent ideas for how that can get into education. But one of the problems in the United States is that we have 50 states, and each state is kind of on its own. And as you know, the United States never ratified CEDAW. We never ratified child rights agreements. The United States is really backward in some of these things because of the issue of each state having to do it itself. So I kind of think maybe some of us in the United States should think about whether we can take a couple of different states and try to tackle some of these issues in a state and maybe provide a model. And if Saria has some, I forgot what the term was you used, a best practices model, that might be something we could look at and see how we could apply it in one of the states where there are a lot of immigrants to get started on how to protect and respect immigrant populations.
Yeah, and actually, a lot of states do have very large immigrant populations who have sort of organizations. Yeah. So SAM is a medical organization, but we've partnered with some community organizations, in different states that are based in Sudanese diaspora groups. So that would be kind of a good place to start. You know, I don't know if you've talked about places of worship as well, because I feel like that's one place where people kind of magnate towards and kind of confer at, and that's what I've seen in some of these immigrant populations. So have you reached out to these places of worship and religious leaders? I just want to ask you about that.
Was the question for me, or am I okay to answer that question? Because
Yeah,
that is an interesting one we saw. So I think I know start with kind of what Ellen had mentioned. We had one of my colleagues at Forward moved from the UK to America to work on FGM and child and early forced marriage, and was talking to me about the challenge of it being state by state. So I'm trying to remember the name of the organization she was working with. That sort of it's based in Washington, and they were trying to slowly build up that momentum of each state having laws. But I would be more than happy to kind of send across via email the best practice guide that we developed through the Tackling FGM initiative.
It might be the Ayan Hirsi Ali Foundation, which has some of its own problems, but it has a lot of guidance about laws and things like that. I don't if that's based in Washington. Could that be it?
I want to say it's Tahira.
Oh, no, I don't know.
Tahira?
Oh, I don't know that one.
Can
We'll talk later by email, shall we? Keep in touch.
Yeah.
So, yeah.
Yeah. In terms of kind of the use of community-based organizations, just like I'd say within the Tackling FGM initiative, that's predominantly the organizations that were being used. So it could have been, for example, like a small Somali organization that had networks with its local community, maybe was providing like childcare services, already is trusted. And then they built up the expertise to do FGM and got that funding. So I think it sounds like a good idea of reaching into those spaces. With religious leaders, it was sort of mixed in the UK. I remember one of my very first conferences I went to, we had an Islamic religious leader who came in from, interestingly, America. He started off great, and he was like, "Yep, FGM, it's haram, astaghfirullah, you need to stop it." And then halfway through his points, he was like, "Well, you know, FGM type 1, it's just a little nick, that's okay," and kind of veered off message. Thankfully, a lot of the participants within that conference challenged him, which was great. We thought it was very odd because although he was an Islamic leader, he wasn't from an FGM affected community. And we were like, how did they not vet? So I think we have developed guidance around using religious leaders, and it's really, really important that you're vetting them and making sure like your messages are on board. Within the UK, I know that the Muslim Council of Britain issued a statement to say FGM is not Islamic. It is, and kind of tried to counter some of that message, because what we were seeing was when people got challenged by it, particularly by like somebody who's white or not from their own community, they would just go, "Oh, God told me to do it," and that would shut down conversations. No one felt able to challenge people. So even if you didn't believe it was religious, you just used it as a way to get out of a conversation with a social worker or with a police officer. So it was tricky.
Cool. Any other comments or questions?
Yeah, can I comment?
Yeah, please.
Yeah, I'm glad you brought up the issue of the religious leaders, because from our experience in Sudan here, and working with countries in the region like Egypt, Somalia, Djibouti, issues related to religious leaders are very context specific and very locally specific. Because even in, like, if you bring, I remember in the early 2000s, one of the Azhar religious scholars issued a book, and he was very clear about it. And we try to use that here in Sudan. But then people will always tell you, "Oh, no, but he's not in Sudan. He's not Maliki, he's Hanafi. So this is a different sect." So it doesn't apply to us. You have to get us somebody who's Maliki. So then Sheikh Al-Karuri did a book saying that FGM was required for boys, but it was not required for girls. Again, people were saying, no, 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 but we don't believe in a Karuri. We have our own share. This is here in Sudan. So we learned that for every context, there is a religious person who sometimes may not be a very educated, well-informed religious scholar, or hierarchy-wise a very high-level religious scholar, but he can turn things on and he can turn things off. And that makes it very difficult to have that big religious statement or this huge fatwa that everybody, we were running after it and it didn't work. So when the UNFPA regional office established Shawamikh, which is a network of religious scholars from Djibouti, Somalia, Sudan, Egypt, and Puntland. So they came together and they had several meetings and they did a lot of trainings. But then they all came up to the conclusion that they had to do it very specifically. So like in Sudan, we had like 4 or 5 people, including somebody from the church, because at the end of the day, everybody has their own sheikh, they have their own somebody who they believe in. So it has to be very context specific. And I don't think in diaspora it's any different. When I lived in Manchester and the NHS there started working with Somalis, uh, people who were migrating from Somalia and Sudan, the Somalis were very strict in having their own religious leaders and having their own midwives to deliver the women. And it was a huge issue for the NHS to allow women to deliver at home at the hand of that, because of what you mentioned earlier, Afaf, that people were not, and I'm talking about the late 90s. So people were not aware of the fact that these women have different kinds of genitalia and you will not be able to handle it. And this is when Pambak started the training of gynecologists and obstetricians and midwives on how to deliver women who have FGM, and this is where the defibrillation came in. Again, one thing about the defibrillation, it is very Somali specific because some of the Somali tribes, they have different type of FGM. They don't cut, they just stitch. So the defibrillation is done before marriage and it restores almost everything back. But when it comes to Sudanese and other tribes of Somalis and some Egyptians, because there is cutting, the defibrillation, it only allows as Saria said, sexual intercourse, and it allows the child to be born vaginally, but it doesn't restore everything back. And all people need to have some kind of counseling beforehand. So what I want to say is, despite having these regulations and rules and guidelines, just as we do here in Sudan, our experience here tells us everything has to be context specific. And so the guidelines have to be generic, but then people have to be allowed to change things the way they want to be. In some places, the grandmother is more important than the religious leader. In other places, the school teacher is the person who has a say over everybody. And in other places, it could be just that midwife who can shut everybody down and do what she wants. So, I mean, and you have to now, because you have a huge community, I think you need to be context specific like this. Maybe in the 90s, because there were fewer people. And now you have a larger populations, and you have people from different parts of Sudan and different parts of Egypt, different parts of Somalia and Eritrea and Ethiopia. You really need to be context specific.
Could I also mention, I'd like to come back to the point about the female genital cosmetic surgery, because I think there's one of the interesting things about the law and the issue on the in the United States when the federal law was thrown out. They did raise the issue about gender equality, and we are now seeing some important developments in the United States in some places of trying to introduce laws that try to limit child genital surgeries for boys or for intersex children or people with ambiguous genitalia until they are old enough to have some say in the matter, which raises a really interesting issue for girls. By the same token, the girls who are in their teenage years and choose to have genital cosmetic surgery because they want to conform to some beautiful ideal they have from whatever source they saw it, like some of the plastic surgeons are putting before and after pictures of genitalia that really, it seems to me, are pushing conditions that are, you know, very serious alterations of genitalia. And why are these girls subjected to that kind of pressure for conformity? And why are they feeling stigmatized if their genitalia are more fleshy or whatever it is that they're avoiding? So the fact that white girls can do this, but women, adult women, cannot, or if they're African, this is a really big issue. I think it's a very, very big contradiction. And just secondly, about places of religion, I do think religion plays a big role. It does need to be local. I agree with Nafisa from what I've seen. And some of the Islamic centers in the United States, I know, include people from so many different countries. And very often they don't, I can't say very often, but in my experience, which was limited, it seems like people from certain countries dominate the discourse of Islam in the United States, which makes it a little bit more difficult for people who are not from those dominant countries. And I think probably Sudanese Muslims in the United States have found ways to work around that. And I'm not too familiar with what that is. So, but I agree with what Saria said about that, and Dr. Nafisa also.
Yeah, these are all very, very interesting points. And I think, you know, as you said, times are changing and, you know, societal norms are changing within, you know, the Western countries, and the Western, you know, ideals are changing as well, right? So it's very interesting to see how things are changing and how that reflects on the diaspora. Any other comments? I think there was another comment in the chat that we might have missed. Oh, I think there was this discussion of the custody situation where, you know, the FGM accusation was used as sort of a part of a custody battle, which is really unfortunate. Okay, I don't think there are any more questions or comments in the chat. So if anybody else has anything to say, please share, or I think we could basically.
I think we should thank you for hosting this and doing such a good job, Afaf, of keeping us on task. And we went over time, not by too much. And I think it just shows how much there is to talk about in this issue. And
Yes.
Nafisa, you're unmuted.
I mean, that was.
Yeah, I think. Yeah, and I was just going to say, to reiterate what you just said. I mean, it's a hot issue. My husband was just commenting that if the three of you continue talking, you, Ellen and Saria, being so motivated and about the issue, you can continue talking till the morning. so it's yeah, there is a lot to learn. I've learned a lot from presentations of Ellen and Saria, and I think there is a lot that people can do together between home countries and the US and the UK.
Absolutely. I
So
look forward
thank you
to
very
that.
much for that.
I hope this becomes the beginning of new collaborations, you know, between all of us. But again, I want to thank you. I've learned so much. I've really enjoyed talking to all of you and listening to you. And this presentation will be up on our Facebook page. So, you know, we can continue the discussion in the comments.
I'm waving.
Okay, thank you, everybody. We're going to stop the presentation.
Yes, thank you everyone for joining us today and for your time. It has been a really learning experience for all of us. I think I've learned a lot too. It's not my area of specialization, so it's really intriguing. I just wanted to give a very brief comment about involving the religious leaders and the religious organizations. it's a very sensitive issue, and any comment from anyone can be taken out of context by the media. And we had an experience here in Virginia, a year ago, where one of the religious leaders at the mosque mentioned that, type 1 is prevents the woman or the girl from being hyper sexually active. And then he was forced to retract his comment, and he was really, I think he even had to resign his position at that specific mosque. So I just know about it from the media. I don't have any personal contacts in there, but it just shows you how sensitive the topic is. Although they can be influential in delivering the right message, but any small comment can, expedite the whole discussion and change it into another direction. So we just have to take it step by step, slowly, gradually, and change takes time at all levels. Thank you again, Prof. Ellen, Prof. Nafisa, Saria. It's really a pleasure meeting you today and learning from your experience. You've done a wonderful work out there in the UK, and I'm sure we can make use of your experience here in the US. Thank you very much, everyone, and thanks to our guests who have not shared anything with us today, but we can hear from them. If you have any comments or suggestions or questions for our panelists, please reach out to our by email.
Thank you.
Thank you.
Yeah, thank you very much. Okay.